Hello and welcome to another episode of This is Your Brain on Drugs Psychiatry podcast with your host, Dr. Cody Armstrong. This is the second episode that I'm recording. I learned something from the first episode. The slides did not go through, so I apologize on the YouTube. You only see me, you don't see the slides, but the slides on the first episode are just an overview of the show, so not a huge deal. The slides for this episode are going to be much more pertinent and useful, I think, for people to have. And so if you want to follow along with YouTube, hopefully that's going to work this time. So I'm going to start off with antidepressants. These are the most common medications that are out there from a psychiatric point of view. They're medications that every profession uses. A large percentage of the population is taken, and I think that people will be most interested in this. So I'm going to kick it off with this. So let's get started. So let's do an overview. And this is just a map here of the prevalence of depression. Um, I'm not sure how relevant this is. I think what you're seeing here is there is a stronger levels of depression in some of the Appalachian states, some of the southern states, but really depression is pretty prevalent in the country as a whole, in the US where I am from and the episodes are coming from. So, and it's on the rise and amongst all age groups, and especially we're seeing a lot amongst kids. So depression is a huge problem in the country and in the world. So I want to mention some of the comorbidities. So depression is a big thing, but you're going to see anxiety with that. You're going to see PTSD and depression have some overlap, a lot of your substance abuse disorders. So, a lot of your psychiatric disorders are going to overlap with depression and medical disorders to a large extent. So, I've dug up some studies on cardiovascular disease because there's a huge overlap with cardiovascular disease and depression. So, depression actually confers a 3 to 5 times increased risk of cardiac related death at 6 and 18 months after having a heart attack. That's pretty huge. So if you've had a heart attack, you know someone that had a heart attack, their risk of having depression is significantly goes up after that. All right. And so in a study that was done of 51,000 patients who suffered a stroke, patients diagnosed with the mental health illness 1 month after the stroke had a 33% greater chance of dying within 3 years, even though they were younger and had fewer chronic conditions. So, what that's basically saying is you've had a cardiovascular incident and you have depression. So, not everyone does, but for those that do, their chance of dying after that stroke, if they have depression on top of it, is significantly more. And I think that makes sense to everyone. But I mean, to see that 33% greater chance of dying within 3 years, that really puts a pretty big number to it. So, in another one, a third of heart attack survivors experience depression versus 1 out of 20 adults in the general population. So, 1 out of 3 heart attack survivors versus 1 out of 20 in the general population. That's a huge difference. Okay. And in women, the symptoms of depression were 50% more likely to develop or die from heart disease than those without such symptoms, even without history of heart disease. So that was another study. And then just looking at some other disorders, I think, those of us in the in the medical field, we're pretty familiar with this kind of stuff. Inflammatory bowel disease, pain disorders, cancer, neurological disorders, autoimmune disorders, fibromyalgia, even metabolic syndrome. I'm going to do, I think I'm going to do my obesity medicine lectures next because it's such a hot topic right now and it's just so related to so many things. So, those with metabolic syndrome, greater chance of overlap with depression. diabetes, dementia, migraine headaches, um, all those we're seeing in greater amount and comorbid with depression. So, and there's a lot more. Those are just some of the big ones, and those are some of the most common ones. So, let's talk a little bit about the epidemiology of depression. So, lifetime prevalence of depression is around 15%. I've heard higher numbers. I've heard up to 25%. So that's like 25% or 15% in this statistic that I had here of people in the United States are going to have the diagnosis of depressive disorder in their lifetime at some point. That's pretty high, right? I mean, up to a quarter of people. I mean, that is a pretty big number. And so it could be as high as 25% in women, I saw on some other research articles. And women have a greater risk than men of having depression. So that women tend to have more likelihood of getting depression than men. Although with men, it's often more severe and more devastating. So we'll talk about that a little bit later when we talk about suicide. So also the incidence in children and adolescents, as I mentioned, is going up. The mean age is around 40, but I don't, that's just it really covers, and I think 40 is kind of the average age of a human being. So we're seeing a lot of it through all the years of life. And it's more common in those that are divorced or separated. It's more common in rural areas. It is often underdiagnosed in minorities, and the prevalence isn't associated with race or socioeconomic economic background. So, what we're saying there is there's we're not seeing a big difference between those groups, but we're we think that it's the same rates across race and socioeconomic background, but we're not getting those numbers. And I've got a chart on that a little bit later. Um, and amongst the unemployed, they're 3 times more likely to have a major depressive episode. And 40% of patients with major depressive disorder also meet criteria for dysthymia. So, this is a slide here about the rates in the world, which I'll touch on briefly. So, close to 1 million lives are lost every year on Earth due to suicide. I think I looked recently and it was around 800,000. So, that's around 3,000 deaths a day. And some of the highest rates are found in Central America, Central Asia, and Southeast Asia. And if you look this up, the it's not a country per se, but Greenland actually has astronomically higher rates of suicide than anywhere else on Earth. It's number one, and number two is not even really close. So that's some of those northern areas of northern Canada, Greenland, have particularly high rates. But generally, rates are high and rising across the world. And what's the cost of depression, right? When you compare it to a lot of other illnesses, it's actually comes out as like the highest. And I mean, it's a little hard to estimate these sort of things, but we're looking at like the medical costs, the costs of the medications to treat it, the costs of folks are not able to show up for work or school or their occupation or whatever it is that they do. And then a big one is something called presenteeism. And so that is they actually did show up, but they're not operating at full capacity because the symptoms are slowing them down, making them less effective. And when you look at if you're looking at the chart on YouTube, what you'll see is that depression and obesity actually have the highest rates of the presenteeism, and then anxiety being the third highest. And those are all, two of those are mental health disorders, and then obesity, I feel like, cuts across everything as well. And so when you try to estimate all those costs, what folks are coming up with is that depression is costing the most. And the particular chart I have here is several years old, but it's come up with $350,000 there. So moving on to the course of the disease. Okay, so how does this disease of depression what's its course? How does it start? How does it go on? How does it finish up, come back? So in general, mood disorders, depression being a mood disorder, have long courses and frequent relapses. So we're seeing that these symptoms, they tend to be chronic in nature. And when they do get better, there's a tendency for them to worsen again. So in 20 years, the mean number of episodes that somebody who gets this, they'll have 5 to 6 of what we'll call major depressive episodes, and I'll talk about what that is a little bit later. But, that's a lot. And so it tends to happen again and again. And if we have an episode that's untreated, so we're not giving the person treatment, they're not seeking treatment, and we're not just talking about meds here, we're talking about any kind of treatment. Episodes on average last between 6 to 13 months. That's a long time. And especially when you consider someone might have 5 to 6 episodes in 20 years that they last up to a year each, that's a significant amount of somebody's life. And when the episodes are treated, on average, that cuts back to 3 months. So still pretty long. And I think those of you that have treated this know we can't get folks better quick. And I mean, I think 3 months is, wishful thinking, but it certainly is going to last less long if they're treated versus not treated. So, what are the risks of recurrence? The more episodes of depression you have, the higher the risk that it's going to happen again. So if you've had one episode of depression, there is a less than 50% chance that you're going to have another one. If you've had a second one, that chance goes to up to 50 to 90% chance you're going to have another episode. 3 episodes, and you're talking about more than 90% chance. So if you've had 3 episodes, chances are you're highly, highly likely to have another episode of depression. So as the disorder progresses, episodes become more frequent, more severe, more resistant to treatment, and last longer. So just worse, 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 worse. So that's why it's so important that we get ahead of this and treat it as soon as possible, so that, because when more resistant to treatment, so we're talking there, like if we don't treat it sooner, the patient is less likely to even respond to treatment. And so it's so important to get ahead of these things. And then when we're talking about dysthymia, usually folks that get dysthymia, and that's a little bit different than depression. For those that you don't know, dysthymia is the symptoms of depression that tend to be a lower frequency, like lower severity of symptoms. So you don't have quite as many symptoms. Your functioning is not quite as bad. It's not quite as severe, but they last a lot longer. And so dysthymia, folks that have that, they often go 10 years or longer before they even seek help. And also, dysthymia is notoriously more resistant to treatment. So only 10 to 15% are in remission a year after they were initially diagnosed with dysthymia. And of course, dysthymia is an older term. It's now called persistent depressive disorder. So kind of a little bit of a replacement there for those of you that maybe have heard both terms. They do mean the same thing, but we now call it persistent depressive disorder. And only about 25% of those diagnosed with this come to a complete recovery. So a lot lower. So, what are some good prognostic factors? So, these are things that if a patient's got this, that they're more likely to get better, right? So, history of solid friendships during adolescence, stable family functioning, having a generally sound social functioning for the last 5 years, absent of comorbid psychiatric disorders, including things like personality disorder. So we don't have like other stuff going on. It's just purely the depression. They're more likely to do better, and then no more than one hospitalization. And that makes sense. But those top three are all kind of related to social support, family support, friendship support. So people that are isolated, people that don't have as good a support there. Um, I mean, it makes sense that they wouldn't do better, but like that's huge. If we can find ways of strengthening those, and psychotherapy is a great thing to do to work on those things. If we can make those things better, it's going to make a huge difference to the patient having a better chance of recovery. And so, what are some poor prognostic factors in depression? So, longer episodes, if they have psychotic symptoms, psychotic meaning that, they're not they're not sensing reality as you and I do. They hearing and seeing things that maybe aren't representative of what reality is. So having those psychotic symptoms, having poor premorbid social adjustment. So they don't have that good social support. They have difficulty engaging with others and informing good close social relationships. Males have a worse prognostic. Uh, they tend to be more stubborn to recover from, and when I say stubborn, I don't mean that they're stubborn, but the symptoms are more stubborn to respond to treatments. Having the dysthymia on top of depression, so you can actually have both. You can have the persistent depressive disorder, and then you can have the major depressive episodes on top of that. So if you have that kind of underlying simmering low level depressive symptoms, in addition to sometimes you go into these episodes where you have the worsening of symptoms, those folks tend to do worse. Substance use issues, so alcohol, drugs, these sort of things, people are using these things, they tend to do worse. And then having anxiety on top of depression, or like an anxious depression or something like that, so just having comorbid symptoms, that's going to be worse as well. So if we can work on eliminating those, making those things better, that's going to help the patients a lot. So I want to talk about suicide just a little bit. I'm not going to go too much into it. So when you're looking at men versus women, women are 3 to 1 more likely to attempt a suicide, and men are 4 to 1 more likely to complete a suicide. I think a lot of people have probably heard this. Women do have a tendency to make more attempts, whereas men tend to use more lethal means. So men are more likely to use firearms, women are more likely to use medication overdoses, and firearms are extremely lethal in the rates of 90 plus percent, depending on what they used, versus medications are more in the maybe 5 to 10% range for lethality. And so if you look at here, so men 57% when they attempt suicide use firearms versus 32% for women. Suffocation, it's about the same, 23 to 20%. And then poisoning, so poisonings are overdoses, 13% for men, 38% for females. So just some statistics on how that pans out. And then looking at suicide rates, I've got here the rates in 2020 by race, ethnicity in the United States. The highest rates are seen among non Hispanic American Indians and Alaska Natives. So these are your Native Americans and Inuit peoples. They have higher rates of suicide. And I think that's where, when we were talking about Northern Canada and Greenland before, those are those folks, right? I think I'm not going to speculate too much on, why that may be. Personally, I think it probably has something to do with their cultures being so removed from them, and not having good connection with, consistent cultures and past that may have a big thing to do with that. But not going to speculate too much on that. But those, we do tend to see higher rates in those populations. Next, non-Hispanic whites, so this Caucasians, um, tend to have the second on suicide for race and ethnicity. And so, and when they're doing this in percents, this is the chart. If you look at it, it's the age adjusted rates per 100,000. So this is how many suicides per 100,000 of the population. And in the non-Hispanic American Indian Alaska Native, it's 23.9 per 100,000. For non-Hispanic white, it was 16.9. For non-Hispanic Native Hawaiian and other Pacific Islander, 12.5. Non-Hispanic multiracial, 9.6. Non-Hispanic Black, 7.8. Hispanic 7.5, and non-Hispanic Asian 6.4. So those are rates of suicide per 100,000. And then this next chart, it shows between the years 1999 and 2021, the deaths per 100,000 of suicide per year. And what you'll see if you look at a chart like this is that the rate went up, pretty much went up every year, and peaked around 2018. And then it fell in 2019, 2020. I'm not quite sure I mean, we know COVID happened in 2020. Not sure why the number was dropping in 2019. Not sure if maybe we were doing something right there. And then rates have actually gone up since 2020. So they've then surpassed the 2018 rates. This chart only goes to 2021, but I've looked at 2022 and it's higher than the 2018 rates. And so I think the pandemic probably had an impact on kind of halting things maybe in a little bit, but then at the same time worsening them. And now we're seeing the rates go back up again. Not quite sure why, but the general trend is higher and higher rates every year. So I'd like to talk about pathophysiology next. So why does this happen? Right? Why do folks get depressed? What is going on in the body? There's a lot of theories out there. Okay. So, and I think there's a grain of truth to all the things on this list. And it, by person, you might have more influence of one versus another. So, just to go down through this list, and then I'm going to go in detail and kind of describe what we kind of know about this. So there's likely genetic factors. So if you have a family history of depression, it's more likely that you would get it versus someone who didn't. There's epigenetic stuff. So that's kind of, things that happened in the life of your ancestors. We think about, maybe your grandfather had childhood adversity, lived through a famine or something like that, and that affects his genetics that he passes on to the next generation, et cetera. So there's likely some epigenetic factors, environment. So that would be like if you're exposed to maybe toxins or pollutants, things like that. Diets, what you eat. I mentioned before about the metabolic syndrome and obesity. There's pretty clear evidence that if you have a healthier diet, you are more likely to not be depressed. I actually have a presentation. One of our episodes is going to be on this topic specifically, where I'm going to go through the studies on the links between diet and depression. So, exercise would also be in there. There is a correlation between exercising, cardiovascular health, and improved mood. And then moving down to kind of the next category would be the monoamine deficiency. This is the one that has been out there for decades. where, when people, you might hear, they have a chemical imbalance, or someone say, I have a chemical imbalance. This generally is thought to not be terribly accurate by today's standards. People likely do not have a chemical imbalance. That's not to say that there aren't some disorders where this might be playing a role, but for the most part, this is fairly debunked. It was generally thought in the past that this was the major contributing reason, and now it's a very minor. Um, and moving down the list, so altered HPA pathways, so that's your hypothalamic pituitary axis. So that's some hormone issues. Thyroid would be in there, cortisol would be in there, some of the endocrine disorders would be in there, or disruptions in that pathway likely has some contribution. Neurotoxic neuroendocrine effects, so things that are causing brain damage in one way or another is likely to have an impact on mood. Reduced GABA, that there's some thought that GABA is a chemical transmitter in the brain. We'll talk about it more in the anxiety lecture, but that may have something to do with depression. And then an impaired circadian rhythm is another kind of thought. So altered sleep patterns where people are not having a normal sleep wake cycle, that may also contribute to depression. Okay, now I want to go through kind of some more of the scientific details of what we currently understand about how depression happens. Okay, so the the process of kind of, mood and depression is centered in the limbic system and the circuit of Papez. And likely contributing to this is you get atrophy of dendritic spines. So this is your dendrites are, those are the branches on your cell bodies. So your nerve cells that are in your brain, the den- it's the kind of arms of it where it reaches out and touches other nerves. And atrophy means that they're kind of going away. So you've got a decrease in these connections in this area of the brain. And then you have a decrease of neurotrophic factors, things like BDNF, that's brain derived neurotrophic factor. And then you get reduced size of the prefrontal cortex, and that's the thinking part of the brain. That's the part in the front where we do a lot of our executive function and thinking. So reduced size there, reduced size in the hippocampus. That's where memory is centered, uh, and reduced size and decrease neuronal synapses in these areas. So, synapses are the connections between two different neurons, and so we have a decrease in these, and then a decrease in overall metabolic neuronal activity in the limbic system by 30 to 40%. So, in folks that have depression, these are physical changes that scientists that research this have seen in the brain. They see this atrophy of the dendritic spines. They see these reduced size of these certain parts of the brain, these decrease of certain neurotrophic factors, and the decrease in the overall metabolic neuronal activity. That means that your metabolic neuronal activity, that's the kind of energy engine that's going on, your mitochondrial activity, where you're like producing your ATP and your energy that's running the functions of the cell. We're seeing a decrease in that in these nerves in this part of the brain. Okay. So that's what we kind of see in the brain in folks that are depressed. Now, what's happening? Let's take an example of why someone might become depressed. So, first off, they're likely genetically vulnerable. So, this is somebody who likely has stuff in their genes, whether, their parent, they got it passed on from, their parents or whatever, or it was, there was a mutation that happened, but they've inherited this in their genetics. And then they they encounter a stressor, so something stressful in life. They've had a breakup, or food scarcity, or uh, they're living in fear, they're in a dangerous environment, they're being harmed. Okay, so that some sort of stress has happened to the system in a genetically vulnerable individual, right? And then what happens is the limbic system goes further and further out of homeostasis. Now homeostasis, that's where you have things in balance, right? And so the limbic system it's losing this balance. It's losing its ability to maintain the homeostatic nature of the system. And then we have chronic unpredictable stress, right? So these stressors that I talked about, they're happening over and over, or they're there and they're not going away. It's not like you have a little bit of stress, you deal with it, you go on, you overcome it. No, these stressors are mounting. The person is having a hard time overcoming them. They're having a hard time relieving these stress. And then what happens with stress? Cortisol is released. And then what happens when cortisol is released? You get a decrease in that BDNF I talked about earlier in the prefrontal cortex in the hippocampus. Okay. And then when this happens, we get a decrease in neurogenesis. Neurogenesis is that genesis, that's the beginning of things in the nerves, right? So the nerves are not growing. The connections that they're making, these healthy connections and strong connections, that this is being impaired. We're getting a decrease in this. The dendrite complexity, remember the dendrites that we talked about, the complexity, they're not doing what they're supposed to be doing. They are not making as many connections. And then the spine density, remember the dendritic spines, those are the little tines that are sticking off from your nerve. In the prefrontal cortex, the density goes down. And then you get a hypertrophy in the nucleus accumbens. And the hypertrophy means an increase. And now the nucleus accumbens is getting more activity. And what happens in nucleus accumbens is this is where the whole kind of uh, cortisol system is being um, controlled by, right? And so then the limbic system function deteriorates to the point where the modulatory neurons, so these are the ones that are trying to help keep this other neuron where it's supposed to be, so that these neurons in the RAF nucleus, and that's where serotonin is, and the locus coeruleus no longer have the capacity to push the limbic system back into homeostasis. So remember, we've gotten out of homeostasis, and we've got this increased cortisol, this increased stress, and you've got your norepinephrine and your serotonergic systems, your dopamine systems that we're going to talk about all these chemicals a little later. They're just not able to overcome this anymore. It's too much attacks on the system. And then the the depressive symptoms begin to emerge. And the so some things that we've seen that can actually reverse this damage are ketamine, ECT, antidepressants, botulinum toxin, neurohormones like allopregnanolone, and there's some new medications that use that system, dietary changes, so increased omega-3 fatty acid intake, decrease in processed foods, whole grains. So improving your dietary, we're going to talk about that in subsequent episodes. That can help reverse this damage. Exercise can help it. Environmental changes, so life got better, things got better, right? So these are all things that we're going to talk about, a lot of these things, and how they can help reverse this damage. All right. And some moderating effects would be coping styles, so having healthier coping mechanisms, genetics. So if you've got genetics that make it more likely that you're going to be able to kind of overcome these things, that can help. And then the epigenetics. So if you've got kind of those positive epigenetics, or you've had the childhood adversity, like I said, with the grandfather, had some scarcity in food or whatever, that can moderate it in the negative direction. So what are some mediating effects? So these are some other effects that can affect this system. So the limbic hypothalamic pituitary axis alterations reduced glucocorticoid receptor functioning, altered glucose tolerance and glucose sensitivity, excitotoxicity. So excitotoxicity is kind of, damage to the conduction of neurons. Intracellular calcium can be a mediating effect. Oxidative stress. So, that's why, people talk about antioxidants being good for you. Oxidation is typically a bad thing. It's something that we would want to reverse. So that oxidative stress can cause some problems in the system. Pro Being in a pro-inflammatory state, and this is where I talked about with the metabolic syndrome. So metabolic syndrome, amongst many other things, puts you in a pro-inflammatory state that can have negative impacts on the system. Lower levels of counter-regulatory neurosteroids and pain. So a lot of stuff. And I think a lot of people, when I think there's a lot of people out there that will say things like mood and depression. Oh, it's just in your head. Like, no, it's not just in your head. And it's not just that you have a chemical imbalance of these couple of neurotransmitters. It's a lot of stuff. The brain is the most complicated. I mean, it's the most complicated thing in the universe that we're aware of is the human brain. It is, we know so little about it. And that's where this stuff is being controlled. And some of those things that I listed, those are things that we've been able to look into and say, hey, when this is, this way, it makes things worse. And when it's this way, it could make things better. It's not necessarily, it definitely will, or it definitely won't, but it tends to. We're really trying to understand this. And when you compare what we know now to what we knew 50 years ago, even 10 or 20 years ago, we've learned a lot. And hopefully, as we learn more, we'll come up with some better treatments, because the ones we have now are not quite what we want them to be. There's a lot of medications out there for other illnesses that cure people, that completely relieve symptoms. And the treatments for mental health stuff, for some folks, they get better, but not everyone does. And trying to understand, like, how is one person's brain different than another person's brain, can help us to figure that out. And also, I think if you're somebody who's suffering from this, knowing that, it's not in your head, and it's not, this as simple as a chemical imbalance. It's a very complicated system, and we know very little about it. And we're learning more and more all the time. And that's why it's important to do this research, so that we can better understand it, and we can better customize our treatments and our therapies to each individual, so that we can come up with the right treatment for each individual person. And I think it could give people that are suffering from this, and those that are maybe around people that are suffering from this, some better peace of mind. Oh, it's not my fault. It's not me. I can do something about it. Yes. But this is not a fault of my character. This is not, a fault of something about me. This is something that's going on chemically, and it's a very complicated in my brain, but there's things that we can do to fix it. And there's things we can do to make it better. And there's things that we can do to make it worse. Things like drugs and alcohol, you know? And so that we can make better decisions on how to, because we all want to feel better, right? And we all like have these symptoms from time to time. We may not have the full on disorder. We I think most people would benefit from a lot of the treatments that are out there. Now, medications I would reserve for those that are really doing poorly, but lifestyle modifications, and going to therapy, or doing the things that therapy can do to help you feel better. Those are things that almost anyone could do and improve their functioning in their lives. Okay. So, like I said, it's not this simple idea that it's a chemical imbalance or a monoamine deficiency. But there are a few things where we think that is at play. And these are things that are more like the person has like more of a brain insult. They have more of like a, a damage to the brain from something. So this would be like neurodegenerative disorders like Alzheimer's or Parkinson's or alcoholic Korsakoff syndrome, epilepsy, so it's having seizures, tumors in the brain, stroke, multiple sclerosis, neurosyphilis. So these are things where like we're damaging the brain in a macro way. And so these are things where maybe you have a person that's doing perfectly fine their entire life and then they have one of these things happen to them. It may be more of the chemical going on in that situation. But once again, still a very complex situation. So, kind of to continue on with the pathophysiology, um, the primary problem here is not in the modulatory system, it's in the end organ, which is the brain. And so, this is an analogy that I've heard that really I think can help this make sense to people and relate it to other disorders. So, say you've got heart disease, right? Heart disease is not a failure of the autonomic nerve, the autonomic system, right? And the autonomic system is the system that's automatic that keeps the heart. You don't have to think about beating your heart; it just happens. It's your vagal nerve, things like that are communicating to your heart what to do. So it's not necessarily a fault of that system. But if I give you a med, like an inotropic medication, like a beta blocker, that can help, right? And so the heart disease is actually more caused by the buildup of plaques and, you know, occluding vessels and causing death to muscle tissue in the heart, right? Things like that. It's not the nerve system, and it could be, right? There could be situations where that autonomic system is impaired, but more than likely, heart disease is caused by these plaques and buildups and occlusions and death of tissue. And so, but what we're doing to help with it is we're giving something that interacts with the autonomic system of the heart. Okay. Not necessarily the part that caused the problem, but the medication can help it. You think about the brain in a similar way. So the limbic system, the limbic, is like the mood, and it's a part of the brain. And we talked about it a few slides ago. The disease of the limbic system is not a failure of the chemicals, the monoamines, the serotonins, the norepinephrines, dopamine, right? It's not a failure of that system. However, taking meds that alter the levels of those monoamines can help. Okay, because I think in the past, we just kind of serendipitously found that this med that alters serotonin relieved depression in people, and we were like, oh, well, these people must not have enough serotonin, so giving them something that increases their levels of serotonin will fix the problem because they didn't have enough serotonin, right? So that's that idea of the deficiency of the monoamines, this old idea that is not really relevant in today's thinking, right? But that doesn't mean that increasing that serotonin might help with the system, just in that the heart was helped by the drug that helped with the autonomic system, but the autonomic system wasn't the problem. Okay. I think that's a good way to kind of think about how it's not a chemical imbalance, but in altering those chemicals, it can still show the benefit. All right. So, and when we talk about these medications, these antidepressants, they're not that effective. I mean, it's unfortunate, but only about a third of patients that take them will recover from their depression. Another third will respond, and a third will have no response, and many of them will feel worse. And some of them will feel suicidal. So you got a third of patients that basically recover means it's gone. I'm not depressed anymore. Respond means my symptoms decreased by a certain amount. I have less symptoms. They're less severe. I feel better than I did before, but I don't feel good. I haven't I haven't gotten over the depression. So a third of folks will get completely better, a third of folks will get a little bit better, and a third of folks will get no relief or worse. So not great. Not that. I mean, that leaves a lot of people that this treatment is not going to help them. So, and then also the positive effects that people have with the medications often don't last. When they stop them, they get worse again. Okay. And then just a word on ketamine and ECT, which, ketamine is not really an antidepressant, it's an anesthetic, but it's more and more being, tested and used as an antidepressant. And then ECT that's electroconvulsive therapy. So that's a procedure. Those actually stimulate synaptogenesis. So that's increasing the number of connections between nerves. They turn on a rapid response genes that activate structural genes in the limbic system neurons and start replacing receptors and transport systems within the cells. So they actually put the brain back into a state where it's not doing what it does that makes you feel depressed. And then regarding psychotherapy, life environmental changes, and improved resilience, which we can do through therapy or just, through self help, those effects actually are more likely to last longer, but they take longer to take effect. Now, this is a drugs podcast. I'm going to be mainly talking about drugs, but I think that therapy is likely a better treatment for a lot of people. Now, when we look at studies, therapy and meds show very similar rates of response. So you're just as likely to get better with one as the other. If you take both, you're even more likely to get better. But therapy is a lot less invasive. It doesn't have the adverse effects that medications have. It doesn't have a lot of the stigmas and other things that go along and things like that. And it tends to, if you respond to the therapy, it's more likely that you will continue to function well once the therapy stops. But it does take a lot more, right? It's easy to take a med and see your doctor once a month for a while, and then you feel better after a few months. But you've got to go to therapy, once a week, twice a week, maybe, um, for months and months and months, and work on things in the therapy and work on changing the way you think and behave and perceive things and just kind of breaking that down. That takes a long time, but the effects are longer lasting. So I want to go into diagnosis and assessment of depression next. So I think most people are probably familiar with the DSM-5, the Diagnostic Statistical Manual, number 5. It came out around, oh man, 2013. I think I was a resident when it came out, but the symptoms of major depressive disorder are virtually unchanged from the previous manual. So, in a nutshell, to qualify for having major depressive disorder under the diagnosis, and I really take the DSM with a grain of salt. It is so subjective. I mean, you could argue that, oh, do they have this symptom or do they not? Or, oh, they have this cluster, and everybody has a different cluster of symptoms. And I think a lot of patients get really hung up on, do I have major depressive disorder? Do I have MDD? Stuff like that. And to me, that's less important. What's more important is what's not going right for you. What is and what's causing it? Can we find the cause of your ailment? It might be sleep, it might be a medical issue, it might be a situational issue, right? Whether you have this diagnosis, that doesn't condemn you to anything. And I think people like to have the label, I don't think the label is that helpful. I also don't think that, you know, pretty much everything in the DSM are syndromes. And what are syndromes? They're clusters of symptoms that generally seem to be related to one thing or another, and we class them, this way, and it basically means we don't know what it is. As we've kind of talked about the pathophysiology of depression, there's, half a dozen, dozens of things that could make it more likely or increase the risk, or, be for one person versus another. And to just kind of say, oh, you've got, 5 out of these 9 symptoms, therefore you have major depressive disorder, from an insurance standpoint and getting things paid for and getting meds paid for and getting services paid for. Unfortunately, that's the way our health system works. I don't really agree with that. I don't like it. If you listen to the first episode, you find out I practiced my entire career in the Navy. I wasn't beholden, you know, into this stuff. I didn't have to, justify the diagnosis to give the meds and things like that. And, a lot of you probably out there, oh man, I'm jealous that, you didn't have to deal with that. And it was great. You know, it's great to not have to, basically try and fit somebody into a box that they don't necessarily neatly fit into. And so that's my soapbox on the DSM. But regardless, it's something, if you're a student, you definitely need to know this stuff. If you're taking a test, you definitely need to know this stuff. And if you're a new learner and you don't know anything about this, it's important to have some sort of, basis of, what is this, right? And if we're doing research and we're comparing research from one country to another and one school, academic institution to another, we've got to have some sort of common language that we can be like, okay, this is how you define depression and we define it the same way, so that we can kind of compare results and things. So the DSM is kind of a necessary evil as far as I see it. Like, we need it. It has its place. But when you're actually out there practicing mental health and you're actually treating patients and you're actually doing this and this stuff and you've been doing it for a long time, this stuff is really not that important at all. To kind of get to a point where you know what you're doing, and when you're reading the scientific literature and to kind of know what they're talking about, you need to know this information. But when I have a patient sitting in front of me, I'm not thinking, oh my gosh, what's the diagnosis? And, I'm thinking, what's going on with this person? What symptoms are they having? Is there a medication that I think that might, you know, get in between that to just to solve that symptom, to help with that? Or is there something that's not a medication? Is it better sleep? Is it something else? I, I don't want to, be like, okay, oh, you have this, and because you have this is the first line treatment, and this is what I'm going to give you. And if this doesn't work, I'm going to do this. This is not how I practice. A lot of people do practice this way, and that's part of the reason why I'm doing the podcast, is because I don't think that's a good way to practice. I don't think that's the most effective way to treat patients. I think, you're checking boxes and you're getting you're getting done at the end of the day, and you're help, on average you're probably helping a lot of people, but are you doing the greatest good? I don't know. My personal opinion would be no. My personal opinion is, get to know that person, find out everything about them, really dig down, figure out what's going on, and figure out what you think fits for this particular person. Because if that's not what we were, what I think we need to do, I wouldn't need to do this podcast, because you could just like take out your checklist, go down the checklist, check off all the little symptoms that they had, and then go down your little algorithm and find, oh, I'm going to go with this one, and then this one, and then this one. Oh, none of that worked. I guess I've run out of choices, or I'm just going to keep adding things on. And a machine can do that. AI can do that. A monkey can do that. That's that's not the beautiful art of mental health and psychiatric practice that I want to convey in this podcast. And that's where we're going to get different. But at the same time, I want to make sure everyone listening out there knows what the DSM criteria are. So I guess I said I was going to go off my soapbox, and I didn't. And I'll probably jump back on it over and over and over throughout this podcast, because this is something I feel very passionately about, is this obsession with algorithms and checklists and things like that, which I think are a bunch of crap. So with that, what does the DSM-5 say? So you have to have 5 of the following symptoms on most days within 2 weeks. And you one of those symptoms must be a depressed or irritable mood nearly all day, occurring most days, or anhedonia. Anhedonia means that you're not enjoying things that you usually would enjoy, had enjoyed in the past. Maybe you like to play guitar, now you don't feel like playing guitar. You like to play soccer, you don't want to play soccer anymore. You enjoyed spending time with your family, and it just doesn't do that much for you. That's anhedonia. Okay. So you have to be either depressed mood or anhedonia. And then we need a total of 5 out of all these symptoms: depressed mood, anhedonia, weight loss or gain, difficulty sleeping, too much sleeping, um, not feeling tired, fatigue, not a lot of energy, having difficulty concentrating, um, feeling, having low self-esteem, feeling guilty, or just like you're not good enough and you've messed up and you've caused problems for other people. Um, Something we call psychomotor agitation or retardation. And essentially all that means is either you're like really jittery and like moving really fast and like can't stop moving and thing and shaking, or you're just like really slow and somebody asks you a question and you take a really long time. You think for like 20 seconds and then you give a very slow response. That would be psychomotor retardation. So could be one of those two things. And then recurrent thoughts of death or suicide, whether that is you intend on hurting yourself, or you just kind of think, I'd like to hurt myself. I wish I were dead. I'm not going to do it, but I have these thoughts of not wanting to be around. So just anything kind of in that kind of suicidal thinking. That doesn't necessarily mean you are suicidal or you're going to commit suicide. Um, it could mean that, but it could just mean that you kind of fantasize about it, or think about those sort of things. So, and I don't think it's a bad idea to say that these are symptoms of someone who is depressed. So I don't want to totally say that the DSM is total garbage, but um, to say that it must be during this period of time and this number of symptoms, and oh, you don't quite meet this one or that one, and therefore you don't qualify for getting a certain treatment or that or the other. Let's not split hairs. I take a general impression. Is this an anxious person? Is this a depressed person? Is this a person that can't concentrate or focus? Is this a person who is kind of not in touch with reality? Is this a person that's like wound up too tightly? Is this a person who, what is kind of popping out to me? And I don't necessarily need them to fit this exact definition before I'm going to give them a treatment that would be for it. So, but that is how we define it. So, and then those symptoms, right? We've listed the symptoms. And so now not only must you have these symptoms, 5 of those symptoms, it also has to cause distress or functional impairment. And that's either in work, school, or socially. So, I've had patients come to me, for example, saying, I only sleep 3 hours a night. And I thought I should come see someone about it. And I said, "Well, does it bother you? Yeah, because it doesn't seem like it bothers you." "Oh, no, no, I'm fine." Are you awake? Are you functioning? Are you having any problem? Is this a change? You go through all this stuff and they're like, "No, I'm great. I'm fine. I just thought it was bad that I only sleep 3 hours a night." And I'm like, "Well, if it doesn't impact your functioning, then you don't have insomnia. You're getting the amount of sleep that you need." And so someone might have those symptoms and, you know, they don't feel it doesn't bother them. It's I'm not in distress. And I mean, I think it would be hard to have all five of those and it not cause that for it in depression. But I mean, it may not. They may be like, no, it doesn't bother me. This is the life I want to live. I have a job. I'm able to feed myself. I have a place to stay. I have the number of friends I want to have. Maybe that's none. You know, that's not a disorder. If it's not causing any functional impairment and it's not bothering you, then that's not a disorder. And that's the case with any of the diagnoses that we're going to talk about throughout this podcast. It has to cause some sort of problem for you. And if you're not bothered and you're not having some sort of, and you may say, oh, the fact that they have no friends or they're not married is a problem. But if it doesn't, if it's not, if it's not impacting your ability to basically feed, clothe, and house yourself, eh, and affect your mood and you being distressed, then it's not really a problem, you know? So it's important to qualify that, because people will come in and say, "Hey, I read about this and I have all this stuff, but I feel fine." It's like, okay, then I'll reassure you. I'm not going to be like, "Oh, you're actually depressed and you don't know you're depressed." That kind of stuff irritates me. Where like, and I've had patients where like they've told me that their doctors have told them things like that of, well, he said I had this because, I told him all these symptoms and he said, you have this. And it's like, yeah, but you don't. It's not bothering you. It's not impacting your ability to do the things that you want to do and need to do to stay alive and function as a human being. Then it's not a problem. And I'm not going to shove some treatment that's costing the system money, costing you money, causing adverse effects when you don't need it. So that's actually, I think when people talk about what the diagnosis of depression is, or any diagnosis, they often skip over that one, like, oh yeah, whatever, functional impairment. I think that's huge, right? I think it's huge if somebody doesn't, if that's not causing them issues, right? That's very important to have any of these diagnoses. And then moving on. So the symptoms can't be better explained by a medical condition or effects of a substance. So if you're having this because you're taking a depressant like alcohol or heroin, then major depression is maybe not your problem. Now, did you have the depression before you start using the heroin? Right? Like, or were you like doing great and you just, got on opiates from the doctor, and that we all know this whole story, and then you get addicted to them and you're on the heroin and now you're depressed. And so that's where we have to tease this out, like the chicken or the egg, what came first? If you were fine and then you used a substance and then you started feeling depressed, we need to get you off that substance. This is not major depressive disorder. This is a substance use disorder, and only that, right? But in many cases, people use the substance because they had the depression to begin with. And so, just because you're using a substance doesn't mean you can't have this. But that's why we say symptoms are not better explained by a substance or another medical condition. So, say you've got a medical condition that we could actually fix that medical problem and you're not going to be depressed anymore. And we're going to list some of those here in a second. That's not major depressive disorder. It's the other medical problem. All right. And then also, the symptoms are not better explained by a psychotic disorder. So if you are psychotic and you have a primary psychotic disorder, so you can actually have depression with psychosis, or you can have psychosis and then depression on top of that. You can have something called schizoaffective disorder, which is a mood disorder like depression with schizophrenia. It's very complicated. And once again, this is like splitting hairs in the DSM. But if your depression is caused by a psychotic disorder that we can fix the psychotic disorder, and then you're not depressed anymore, then you didn't have a depressive, you didn't have a depressive disorder. You had the psychotic disorder. But of course, you could have both, right? And that's where the years and years of training that I've had and other mental health folks out there have had to help us figure out what those differences are. And then also the last one, that these symptoms cannot be better explained by a manic or hypomanic episode. And we'll get into that when we talk about bipolar disorder. So basically, that's, you have the up mood and the down mood. The down mood's the depression. If you have that hypomanic or that manic episode, you don't have major depressive disorder, you have bipolar disorder. So we can't call it, you can't have bipolar disorder and major depressive disorder. You can't have both of those. It's one or the other. So if you've got the mania or the hypomania, then it's not major depressive disorder. So, but we'll talk about that when we get to those episodes. So I mentioned before that there can be medical causes of depressive symptoms. So what might those be? So you could have a thyroid problem. not enough thyroid hormone, too much thyroid hormone. Both of them can cause depression. Diabetes can cause depression. So like unmanaged diabetes, right? Diabetes is a disease of basically insulin sensitivity, resistance, right? You're resistant to insulin, you got too much glucose, sugar molecules flying around your body, and having too much glucose causes damage to end organs, blood vessels. That includes the brain. That can cause depression. So unmanaged diabetes can cause depressive symptoms. Parkinson's, actually 50 to 75% of Parkinson's. And I mean, what's Parkinson's? We're losing dopamine. I mean, you lose dopamine first in more of the movement type stuff, but then you start losing dopamine in other areas as well. And I'll probably cover Parkinson's later, but you're losing those chemicals. Now, here's where we're talking about someone with actually a chemical imbalance. We're actually losing those chemicals because the Parkinson's disease is destroying them. So, epilepsy, actually 30%, I have this statistic, 30% of people with epilepsy, this is a disorder where people have a lot of seizures, have a suicide attempt. 30% suicide attempt, very high. Multiple sclerosis, 25 to 30% of those folks have depression. And that's a disorder of nerves. So we're losing the conductive substance, the myelin sheaths on the nerve cells, where that's going away. So our nerves aren't conducting the way that they're supposed to. And of course, nerves are involved in our mood. We talked about that before. Alzheimer's. Alzheimer's is the loss of brain mass. So we're losing brain. Our brain with Alzheimer's, your brain is shrinking. Your brain is dying, and so of course that can affect the mood parts of our brain as well. We'll go into Alzheimer's in another episode as well, and then cardiovascular stuff. So cardiovascular accidents, which are like strokes, myocardial infarctions, heart attacks, chronic uh, CHF. It's an enlarged heart. CAD, that's coronary artery disease. So all these kind of, I talked about those studies at the beginning of this episode. And then HIV AIDS can cause depression, cancer, fibromyalgia and pain disorders, rheumatoid arthritis, lupus. I mean, lupus is like system wide. We've got inflammation all over the place. I actually had a patient that she primarily came in with like a bipolar presentation. And the more I was kind of like getting to know her, I started to think this patient has lupus. And she had tests run earlier that were negative, and then I reran them, and it turned out she did have lupus, and it presented with bipolar disorder symptoms. So lupus, it you have inflammation all over your body. It harms like all your organs. It's a really nasty disease. Um, Going on, adrenal disorders. So that's where cortisol is in your adrenal glands. Those are the glands on top of your kidneys. Vitamin mineral deficiencies. So like basically malnutrition, right? You don't have enough B12 or B6, B1, folate, D, C, magnesium, zinc, like all sorts of things. If you're malnutritioned, those vitamins and minerals are cofactors. They're used in chemical processes in your body, and your brain won't work correctly if it doesn't have these in there. And so depression could be a consequence of that. And then anemia. So, that means your blood is not, you don't have enough oxygen circulating throughout your body. So your tissues are not getting perfused with the oxygen that they need. And and oxygen is used to run the chemical reactions in your cells to produce proteins and do all the things that cells do. And so that can affect your brain as well. Lyme disease, testosterone deficiency, Wilson's disease, that's a really rare disorder we'll touch on in another episode. And there are others. And so these are all things that could be causing depression that are not major depressive disorder. And then I want to talk about medications. Okay. Medications that cause, so like medical disorders, that's something that's kind of outside of your control. for the most part. Medications are that's, something that you're taking from your doctor to treat something else, maybe that's causing depression. So there's actually the FDA has these thing called black box warnings, but they're actually called like boxed warnings, but we call them black box warnings because there's a little black box written around it on the package insert of the medication. So if you take a medication, especially if you take an antidepressant, look in there. You'll see the black box and it will say increased risk of suicidality in patients up to the age of 25. So that warning was actually put on antidepressants in 2004. We'll get into that later. I'm going to go into details on that. But how ironic that medications that fix depression can actually cause depression. And, I get patients that are taking medications and I often will stop medications because I think you're worse since you started taking this. I think somebody put you on this with good intentions. It caused the opposite reaction and let's get rid of it and maybe use a different type of medication. But first, let's see, maybe are you going to get better when we stop this? It's like I wasn't having suicidal thoughts before I started taking this medication. I mean, I was depressed, but so that warning was placed in 2004. And it also includes not just antidepressants, but all the antipsychotic medications that are approved for use in depression. We will talk about that in this lecture series on antidepressants. We will talk about the antipsychotics that are used for depression. VMAT2 inhibitors, we'll talk about that in our antipsychotics lecture that treats tardive dyskinesia. Actually, only the VMAT2 inhibitors that are specifically for Huntington's disease and not for tardive dyskinesia have the warning of increased suicidality. That warning happened in 2008. Mefloquine, that is an antimalarial drug. 2013, I actually had a patient that had taken mefloquine. He was in the military. It was something, when you deploy out in the world and you go somewhere where malaria is, going on, they would give folks this medication to prevent them from getting malaria because malaria sucks. You really do not want malaria. And so, but this particular one, years later, it, there's thought that this actually can cause some damage in the brain. Anyone out there that took mefloquine feeling depressed, that might be the reason. You don't even have to be taking it now. I mean, typically with the antidepressants, antipsychotics, we stop them, we don't get the depression anymore. But the mefloquine, in this one case, I actually had this one patient and he was quite convinced and he had all this documentation and we reviewed and I thought it was reasonable. I gave him Zoloft. I gave him sertraline and it seemed to help. But, there was a thought that mefloquine may have caused his depression. And then the most recent medication that was black box warning added for suicidality is montelukast. Okay. A medication that is used for asthma and other breathing disorders like COPD, things like that. So montelukast the warning was added. That's singular for those of you that are more familiar with that. So, that's a pretty common med out there. If you're on singular and you're like, hey, I'm depressed and I don't know what's going on. And hey, that actually did start around the same time I started taking that singular. Go to your doctor, ask them to take you off the singular and try something else. Don't just stop it though. I don't want you to have a asthma attack and die. But yeah, that medication could be the reason. And that's why, we don't just add meds to people. This is why I don't just give people, an SSRI antidepressant because they're feeling depressed, because it could be that they're taking a medication that's causing it or a million other things. All right. Varenicline, Chantix, was used for smoking cessation. It once had a black box warning for depression, removed. They found that to be unsubstantiated. We will talk more about Chantix. I really like Chantix, varenicline. It's an excellent medication to stop smoking. I love it. Um, it can cause some mood issues, but you don't take it forever. So if I can get you off that tobacco, I would really love to see that happen. And if we can get through it, if you're having some side effects, you only need to take it for a few months, maybe. But that warning was actually uh, rescinded about 10 years ago or so. And then those are the ones that had the boxed warnings, but let's go through. There's a ton. If you're looking at the slide, you probably already read them all and you're like, okay, stop talking. I've read all the meds. But so other leukotriene inhibitors. So the montelukast singular leukotriene inhibitor. Others, zafirlocast, xyluton. I have no experience with these, but they they don't have the boxed warning, but they have a similar mechanism of action, so they could potentially cause depressive symptoms. Antipsychotics I already mentioned. Um, anything Basically anything that's messing with the brain and the functioning of the brain gets anything that gets into the brain could potentially cause depression. And that's what you're going to see from this list. Stuff that gets through the blood brain barrier, messes with what's going on up here. All right. Antipsychotics, benzodiazepines. Those are like your Xanax type of medications, your calm down medications, your tranquilizers. Naltrexone, we use that for alcohol cessation, amongst other things. The meds that we use to treat Parkinson's. So basically, meds that we use to treat brain disorders, because they get in the brain, they can cause depression. That doesn't, hey, I'm not saying stop taking these, right? I'm saying that these are potential causes. Anti-epileptic drugs, but it may be a reason to use a different one. If you notice, hey, since I started on this medication to treat this disorder I have, right, we could switch to a different med. Okay. We could go to our doctor, not stop the med on our own. We don't do that. We go to our doctor. We say, hey, I have this. I listen to this podcast. This guy sounds like he knows what he's talking about. And he said, hey, this med could cause this. And just because it could and you have it doesn't mean that the med did cause it. And that's why we go to our doctor, to try and, have them sort it out. I'm not your doctor. I have to remind people of that over and over. I'm giving you information. I am not telling you what to do. Take this information, and if you're a patient, use it to be more educated and talk to your doctor about things. And if you're a doctor, use it to better treat your patients. Okay. So anti-epileptic drugs, oral contraceptives, H2 blockers, those are meds that we use for acid reflux disorders. GLP-1s, oh my goodness, the medications that help us lose weight can actually cause depression. And I've never seen this. This is something that's reported. I've added it to the list. Clonidine, that's an alpha 2 agonist. Is a heart medication, amongst other things. Beta blockers, these are also heart medications. Methyl dopa, that's an antihypertensive medication. Corticosteroids, anti-inflammatory medication. Interferon alpha, something we use to treat hepatitis. Indomethacin, that's a NSAID like ibuprofen, a non-steroidal anti-inflammatory drug. Analgesics, so opioids in particular, and opioid-like medications like tramadol. Antineoplastics, those are like chemotherapy drugs for cancer treatment. Isotretinoin, that's a medication used for acne. Oseltamivir, that's an antiviral. Zanamivir, antiviral. Antiretrovirals, which are medications we use to treat HIV infection. Ciprofloxacin is an antibiotic. Roflumilast, not even sure what that is. That one, I I think, is a breathing type of medication. I'm sorry, that is not a medication I see very often. All right. Well, sorry this episode's so long. I want to get through the rest of the slides on the intro so we can get into the meds at the next episode. So feel free to stop and come back to this. So, next, how do we do the patient assessment? Right? So we evaluate the target symptoms of depression. We already talked what those were. That was our SIGI caps. If you've been to med school or you're a resident or whatever, those are the DSM criteria: depressed mood, sleep, interest, guilt, energy, concentration, appetite, psychomotor, agitation, retardation, suicidal thinking. Right? So all those symptoms of those DSM criteria, we want to assess those. Which of these which of these symptoms do you have? What we want to see what your particular issue is. That could help us figure out what treatment might be the best one for you. Another thing we can do when we do assessments: rating scales. So these are things like PHQ-2s and PHQ-9s. These are depression rating scales. The PHQ-9 basically lists those 9 symptoms and asks the patient like how much each one of those bothers them on like a scale of 1 to 5, 1 to 3 actually. And so your max score would be a 27, meaning that like it bothers you all the time, each symptom, right? And a 0 would, or no, there is no 0. It's, I believe, maybe there is, yes, 0. A 0 would be none, no impairment. All right. And there are other scales out there, and you know there's pluses and minuses to these scales. Patients are not always honest on a scale. In my experience, patients hate filling them out. They don't think that seriously about them, and they don't necessarily give you great information. And so some patients are going to put good information. Some people are going to over embellish their symptoms, and they're going to say, I want to appear really sick on this thing. And it's like, then you can't even tell that they're getting better because they're like saying their symptoms are super high no matter what. And then you got other patients that they look terrible and they're doing terrible, but they've got a really low score. And so I think there's a place for these, particularly in research, and maybe like on one patient to kind of see, are their numbers going up or down? And to kind of maybe, you know, justify maybe doing something with your program that you're doing at your clinic. But how good is this? I would prefer to just ask the patient myself and get the information. I know that can take time, but you're going to get better information. You're just going to get better information. And in a new appointment, you should have more time where you can go through all this, and then you're in subsequent appointments, you're asking about changes. Okay. So what else are we assessing? The comorbidities, their past medical history. So we want to know about all their other medical problems. We want to know about their past psychiatric stuff. What have they been diagnosed with? What meds have they taken? We want to know all that information. Do they have family members that have some mental health stuff going on? Um, what meds are they taking now? Which ones did they used to take? Why aren't they taking them anymore? Just like everything about, like, I want to know when you took it, how long you took it, did it help? Why'd you stop? What happened when you took it? Because I could get you back on that same med. If you got a family member on a med, I can get you on that med, right? If you hated one, I don't want to repeat the same mistake, right? So we want to know that whole med history. And then labs. I don't get a lot of labs for depression. I know a lot of people do. I'm not a huge fan of this. I don't like sticking people. I just don't. Um, Unless it's like absolutely necessary. I just don't think I'm going to learn that much. But in some cases, I pretty much, if you've got depression, there should probably be some thyroid function labs somewhere in there. Maybe you already had it done by your primary care doctor. If not, I might order that one. I'm going to be thinking about, because what are the symptoms of thyroid issues? But that's one I might be a little more likely to get. But typically, patients have already had it, and I can see the results. A complete blood count. If you're suspecting like anemia symptoms, low iron, that would be utility in getting this lab. If malnutrition or alcoholism, or they're on a very strict diet, like a really strict vegan diet where maybe they're not getting their B12, that would show up in a CBC. But you might want to get that B12 separately itself. A chemistry, there's not a whole lot this is a basic metabolic panel, just not a lot I'm going to get from this. I mean, calcium issues could cause depression, but like it's really uncommon, and they're probably going to have a lot of other symptoms of calcium going on. I've never ever picked up depression from a calcium issue in a patient who had a chemistry lab, either by me or anyone in their history. I was, oh, look, your calcium's that's the reason. I've never seen it. Not saying it can't happen, but haven't seen it. Sodium, if you're taking a serotonin reuptake, any kind of serotonin reuptake inhibitor, that can cause low sodium. I'm not in the military, like my young, healthy population, really not concerned about this. In an elderly population, I'm going to be a little bit more concerned about that. So if I've got some older patients, some sicker patients, they probably, and if you're an older, sicker patient, you've already got these labs. So I'm going to probably want to look into that sodium to make sure my medication's not causing that problem in that population. It's not one that I saw a lot of in my career, but it's certainly a lot of them out there, and that would be a reason to be looking at that. Substances, urine drug screen, a variety of different labs. And we'll talk about this when we talk about alcohol, for alcohol detection. You know, we might want to get a drug screen if we're suspicious of that. I tend to trust patients. I feel like patients tend to tell me the truth if I'm honest and frank with them. I think they tend to be pretty honest. And if or I have a suspicion that they're not being, I'll order this stuff. Right. Um, so I certainly would. And then vitamin D, that to round out all the labs that could affect depression. Um, Theoretically, and I've heard this, but I have never. I've seen so many patients with low vitamin D. I've never, ever, not one single time have I had a patient with low vitamin D, repleted their vitamin D, and they weren't depressed anymore. I've never seen it. If somebody's seen it, comment down below. Guys, I'm curious, does this happen? Are there people out there with low vitamin Ds that are corrected and their depression goes away? Please let me know. I've never seen it. So I tend not to really mess with this lab because I just don't see the utility. And, you know, I don't see that patients, if even if I do find it's low, that it actually helps them. I'm sure it's out there, but I just haven't seen it. So those are some of the labs. I tend to check none of these. Um, I I don't go based on, oh, this person's depressed, therefore I'm getting all these labs. No, I would say, what else is going on with them? What are their other symptoms? And we can get into that in another episode. I just want to kind of briefly go through things here. And then suicidality. Of course, I will assess for that. And when we're doing a suicide assessment, we're not going to go into a big suicide assessment in this episode. I'm just going to go kind of run through these. Um, Presence of suicidal, homicidal ideation, intent, or plan. I want to look into this. I want to know about that for sure. Have they ever tried to kill themselves before? And I use the word kill yourself. I don't like this hurt yourself. Um, if you get that information, you need to qualify. Were you intending to die, or what were you intending to do? Not that it's not serious, but it's more serious if you intended to die. And I think a lot of people just kind of they tiptoe around these issues. Have you ever had thoughts, or have you ever done this? And then all of a sudden somebody's been hospitalized that didn't need to be. I see it all the time. And then I get patients that are like, oh my gosh, I don't want to talk to you because you're going to hospitalize me. And I'm like, I'm not going to hospitalize you unless you and I are both worried that you're going to die. Like, we need to be concerned here that you need your safety preserved. I'm not just going to be like, oh, you said something that ticked me off, or not ticked me off, but like, piqued my interest, and I'm not going to get any further details, right? We could do a whole episode on this. But yeah, suicide assessment is a huge part of a psychiatrist's job, and not always done well. Not always done well. So I want to know details. What did you do? What did you physically do? What did you think was going to happen? What are you concerned that you would actually take an action that would end your life? And do they, and sometimes they don't know. And that's information. The fact that you don't know is information. But I don't want to stop asking questions. I want to know all the information. I want to know what is going on in your head when it comes to your thoughts of suicide. Okay? Um Once again, like I said, we could cover that another time. But access to lethal means, so like if someone has access to a weapon, that increases their risk that they're actually going to use it. If they're not having suicidal thoughts in the first place, I'm not concerned that they have the weapon. But if they're having the thoughts and they have access to the weapon and they're thinking about they might use it, hey, that's the concern. So just having a gun, that's not. I'm not going to go crazy on you. If you have severe anxiety, panic attacks, agitation, impulsivity, in addition to some suicidal thoughts, that increases your risk. psychotic symptoms, especially if you have voices telling you to kill yourself, of course, that's a huge risk. If you've had a history of psychiatric diagnoses, alcohol or substance abuse, family history, recent exposure to suicide, someone in your family's harmed themselves, or someone close to you recently, or there's been an anniversary of that happening in someone who's thinking about suicide, that can increase their risk. And that they don't have any protective factors. There's nothing stopping them from killing themselves, essentially. So that's a basic suicide assessment, but there's so much more to it. I don't want to leave it just at that, but just to say that we're going to do a suicide assessment in people that have depressive symptoms. So let's talk about treatments. All right. I actually think that this would be well. Let's stop here. We've gone an hour and a half. I want to cut this short now. We'll go through treatment course. We'll talk about non-med treatments, and then we'll kind of get into the beginning stages of treatments on our next episode. So I want to thank you so much for listening for the whole hour and a half. I hope you enjoyed this. And, if you came here looking for information on meds and you're like, oh my gosh, this guy talked for an hour and a half and he didn't talk about meds at all, you know, I'm building up to it. We're close. And then once we get through the next few pieces of information, we're going to go through SSRIs, SNRIs, NDRIs, the new meds that are out there, glutamate stuff. And we're going to dig in deep. That's what this is about. I'm going to give you all the information, and I'm going to give you I don't want this to be like I'm just reading off of a expert opinion database, like an UpToDate or a Micromedics or something like that. I want this to feel like a real conversation that we're having, and you're sitting in the car and you're listening to this, and you're getting these details, and I'm telling you, like, this is when I would use this drug and this is when I wouldn't, because this is a big thing that I want this podcast to be about. Is I don't want this to just be a general discussion about the topic. I want you to actually know what's the difference between this one and this one and this one and this one. And I want you to see those like side by side. And I want you to be like, oh, that's, how these kind of differ from each other. And that will help you hopefully pick the one that works for the patient better, and make a better choice. And that's really what we want to do here with the podcast. I want to help you know, first, should I even give this person a med? That's first. And second, what, you know, which one to pick, and how do I know? Is it just random? Like, no, I want you to make an educated guess, and I want you to make that educated guess based off the information that we're going to hear about in the podcast. So once again, thank you so much. This is, I think the slideshow worked this time. I'm pretty excited. Um, the slides, everything's going to go up on my webpage, punkrockpsychiatrist.com. Instagram, I'm going to make announcements on Instagram. That's at punk_rock_psychiatrist. My YouTube channel, the same name. Um, we're gonna get into the meds probably next. I might make a short episode next and then hit the meds after that. And yeah, I'm excited. I hope you guys are excited to hear about all this stuff and learn, and it's going to be great. So come back next time and we will get on with antidepressants.